Hey everybody, Dr. Hammond here. We're going to do another medical director education. And today's topic is neonatal resuscitation. So first couple things, any questions you have, certainly get those questions to Captain Pacheco or Captain McNiff, and they'll forward them to me and I'll address them in the next month's education that we do. Or, the other option, your medics at your stations are super knowledgeable about a lot of the things that we talk about. And I think they're probably one of the best resources to start with. And if you need more explanation, happy to dive deeper into that. And you know where I work. So come by anytime. You're always welcome to come by and chat with me and have a conversation or talk about a case or whatever, kind of pops up. So let's get started. The way we're going to kind of go over this one today is really we'll look at our protocol because it really outlines neonatal resuscitation from like the NRP course and how they manage it, and it really kind of mimics that. So it's a really good outline for really your plan in neonatal resuscitation. So let me share my screen with you and pull that up. So we'll start here. So neonatal resuscitation, here's your patient goals, right? This is, sick babies that are born. Let's start with the patient presentation. So in the exclusion criteria, it says documented gestational age less than 20 weeks, usually calculated by last menstrual period. If there's any doubt about accuracy of gestational age, initiate resuscitation. So really this comes down to, we kind of break this into a couple of categories. We talk about, neonatal resuscitation really applies to babies that are greater than 20 weeks. And realistically, probably the real outcome is beneficial when it's greater than 25 weeks. So let's start at 20 weeks. Anybody whose gestational age less than 20 weeks and known less than 20 weeks, that's not a baby that can be resuscitated. That's truly just a miscarriage, right? It's a horrible situation if you come into this, and it's really emotional for most of the family members and patient's family, but you cannot resuscitate a baby less than 20 weeks. They will not live, period. We get to the 22-week mark. That's when we really start to see a little rise in survivability. Most of the literature states, neonatal stuff says somewhere around 22 weeks, if you resuscitate a baby that's in distress, the survivability is about 2%. Once you get to the 25-week mark, that's where survivability really starts to increase. And that doesn't say anything about neurologic outcome in terms of what type of survivability, just the fact that this infant survives. So how do you know if a baby, if a mother's 20 weeks or greater, if she has no idea, of her due date or has had no prenatal care, clinical exam is really where you're going to come back to. So it's your fundal height, right? So you palpate her abdomen, and her uterus, the fundus of her uterus should be at the level of the umbilicus or above, means they're 20 weeks or greater. Anything lower or smaller, below the umbilicus is probably going to be less than 20 weeks or so. So start with that, okay? So with that, those are the babies we're going to resuscitate. Greater than 20 weeks is kind of the simplistic answer. Really, it's, I'll start having conversations at 22 weeks of, is this really a viable resuscitation, and is this baby going to do well? At 25 weeks, I don't even have the conversation. Basically, this is a full bore resuscitation without any questions, right? So that kind of gray area is the 20 to 25 weeks. So this is broken down, like all your protocols, into all providers and what we provide, into what EMT intermediates can provide, and then lastly what the paramedics can do only as well. So let's start with this kind of all providers process here. So first bullet point says immediate resuscitation is required and the newborn is still attached to the mother. Clamp the cord in 2 places, cut between the clamps. And if resuscitation is required, we start with warm, dry, stimulate the newborn, cut the clamp and cut the cord after 60 seconds or when the cord stops pulsating. So this is if you arrive and the mother's in active labor, right? Mom's in active labor, she delivers a baby. We'll save the delivery complications and things to deal with for a different lecture, but let's just say it's a normal vaginal delivery and mom delivers this baby without any complication or any intervention. And now you've got this baby in your hands. If you deliver it and there's a baby in your hands, you want to wait about 60 seconds before you clamp the cord. It's called delayed cord clamping has been associated with a lot of um, decrease in some of the morbidity in babies, and on the positive side has some better outcomes if we delay cord clamping. Really, you only want to delay a minute, minute and a half. That's where the benefit is. If we go much longer than that, we're not really doing any good, and potential harm the longer we go. So clamp the cord, right? It's, here's your cord. You clamp on both sides and cut in the middle, and now you've got the baby. How much do you leave? It probably doesn't matter, right? You don't need to cut right next to mom, and you definitely want to leave enough of a stump for the baby. So if we need to do more resuscitation and do the umbilical line or something in the ER, you want enough of a stump that's there. So a few inches is fine. So you deliver this baby, you clamp the cord, cut in the middle, and now you've got a baby in your hands. And really, as long as the baby's crying, and we define it as vigorous versus non-vigorous infant, right? So if it's a vigorous infant who's squirming, who's crying, who's not grunting, who has good color, good tone, there's not much to do, right? You're going to dry them. You're going to maybe suction a little bit if there's a bunch of mucus in their, airway, but not a lot to do from a normal vaginal delivery with a vigorous infant. 95% of your deliveries are this, right? That's the basis of it. So 95% of deliveries are, neonates are fine and need no resuscitation. And what we're going to focus on is that 5%. You deliver this baby, it's active, it's got good tone, it's vigorous, you dry it, stimulate it, put it on mom's chest, skin to skin, and keep it warm, right? That's the whole basis. That can transport from there if needed. So you've cut the cord, warm, dry, stimulate, thermal blanket. I usually, we start to use, the plastic bags or the thermal blankets and things more with the preemies, right? 32 weeks is really where they have no thermal regulation whatsoever. And those babies need to be in a bag, right? I don't care what it is, some kind of a plastic bag that you can maintain their heat much better. Whereas just a blanket's not going to do it quite as well for them. So warm and dry, resuscitate if needed. We'll talk about that. Keep their head covered with something, right? You lose a lot of heat from your head. If there's a strong cry, regular respiratory effort, good tone, term gestation, and the infant can be placed skin to skin with mother and covered with dry linen. Good, that's normal. Okay, so now let's go to the non-vigorous infant, right? We kind of break this down into three categories, right? There's the non-vigorous infant who has a heart rate greater than 100, a non-vigorous infant who in the middle has a heart rate between 100 and greater than 60. And then there's the neonate with a heart rate less than 60. So we'll kind of walk down what that looks like to resuscitate at each level of that. So at each level just gets greater, more interventions basically, right? We start with some blow by oxygen and suction versus the other side where their heart rate's less than 60 and we're doing a full bore resuscitation with CPR and access and all that stuff. So we'll slowly walk kind of through those. So here, if there's a weak cry, signs of respiratory distress, poor tone, preterm gestation, then you position the airway in a sniffing position and clear airway as needed. If there's thick meconium or secretions present and signs of respiratory distress, suction the mouth and the nose. So this is just simple, right? This is a baby who's not vigorous yet, right? It's been born, it's out, you clamp the cord, you cut the cord, and now this baby's just not responding like you would expect a vigorous baby to do. And so it's a non-vigorous infant. You start with just clearing their airway, right? That's a lot of what they need for the most part. So lay the baby down, and because of the baby's shape of their head, right, they've got this big giant occiput. So if you have a big occiput and they're laying flat, it rocks their head forward a little bit, and they kind of close off their airway as their chin comes down. So you tilt their head back a little bit, and you put them in that sniffing position is what they call it. In that position, bulb suction, both nares, suction the mouth, again, while you're continuing to keep warmth and while you're drying the infant and trying to stimulate them. This is about the time where you start thinking you don't know which way this is going to go. And so with all the hands available to us, you got somebody maintaining the airway, you got somebody suctioning, and then you start getting some kind of pads on them, right? So 3 lead EKG, the defib pads, some way to monitor their heart rate. Just checking a pulse in the axilla or the femoral, you can get a gauge of whether it's fast or slow, right? If it's less than 60, you're going to do something quick. but getting that number, if it's somewhere in between, is it 85 or is it 110? You got to get some accuracy here. So some type of monitor, 3-lead ECG, the defib pads is fine to give you moment to moment kind of heart rate accuracy is what I like to do. So you got this baby, you tilt the head back, you put them in the sniffing position, bulb suction, dry and stimulate. And in our case, these babies are just going to get worse and we're going to go to the next level. But often that is what babies need, right? They just need their airway opened and they need to be able to move through those secretions. Secretions are a big part of what inhibits babies from being vigorous versus non-vigorous, right? It's the common cause. So that's your first step, right? Second step, now we're moving into, if this baby doesn't start to improve in the next minute and a half, 90 seconds or so, then we're going to move to the next thing. So let's look at the next level. If the heart rate is greater than 100 beats per minute, what do you do, right? So you've got this non-vigorous infant, you end up putting the pads on or ECG on, and the heart rate is 110, 115 or so, right? Normals upwards of 130, 140, screaming, crying infant, 150, something like that. So you've got one that's like 110, 115. So it's on the low side, but not low enough that you're going to start any major intervention, but this is something you watch. So it says monitor for central cyanosis, right? You're looking at this skin color. Monitors for signs of respiratory distress. Of course, if apneic, we're going to do some intervention. The other one is their respiratory rate. So normal respiratory rate in a newborn is 40 to 60 breaths per minute. The problem with that is newborns have what we call periodic breathing, right? So they don't breathe regular, that you can count 6 seconds, get a number, multiply it by 10, or whatever, count 10 seconds and multiply by 6. They have periodic breathing, right? So they have some fast breaths and then a short period of apnea, 5 or 6 seconds or something, and then they breathe multiple times again, or it's all variable. So to get an accurate respiratory rate in a newborn, you have to count the entire 60 seconds, right? So clock it, count it, and get a full, what their respiratory rate is accurately over the course of a minute. If it's less than 40 to 60, and you're starting to see signs of, are they grunting? Do they have some cyanosis? Do they have something that shows you that they're in respiratory, it's not failure yet, but it's some kind of distress. But their heart rate is still greater than 100. The first thing that you're going to do is really just provide probably some blow-by oxygen, variable, right? So it's all options are here. Start with some blow-by oxygen and see if they're improving. If things are not looking better, you're still seeing worsening cyanosis, you're seeing continued grunting. The treatment for a baby is positive pressure ventilation, right? So bag valve mask to their face with their, your little PD bag, and you give them room air, positive pressure ventilation. That's really you're going to see babies turn around almost immediately when you start to do positive pressure ventilation, right? It's just giving them that little bit of pressure they need to overcome whatever's kind of inhibiting that, whether it's meconium in their airway, or, all kinds of possibilities. But positive pressure ventilation is really where you're going to start to see some significant improvement in most babies. So heart rate's greater than 100, you're going to do that sniffing position, suction everything, maybe provide some blow-by, and if you're still seeing respiratory distress, you just start with room air, a BVM, and positive pressure ventilation. Your respiratory rate is somewhere between 40 and 60 breaths a minute. So on the high end, it's 1 breath every second, basically, right? On the low end, it's slightly more than less than every 2 seconds, right? So it's somewhere in every second, and you may need a partner to kind of count this out for you, right? To get a rhythm down, because it's a lot faster than what we're all used to doing in every other resuscitation that we do. So let's talk about, before we go to the next level, let's talk about positive pressure ventilation and BVMs, right? So how do you know how much to squeeze this bag so you're not over ventilating a baby? So ideally, you have the BVMs that have the blow off, the peak inspiratory pressure blow off, and then a good seal, and you can provide some PEEP. So if we have those, and that's what's on the truck and available, those are fantastic. If you don't, it's kind of a nice accessory. But basically, what you're looking for is a clinical exam. So chest rise is really where it all comes back to, right? If you're bagging this little neonate and you don't see chest rise, you're not ventilating them adequately. So you've got to get a good seal, got to have an open airway, and when you bag, you should see that chest rise at every breath, right? That's plain and simple, back to everything, right? You can't trust a pulse ox in a baby, right? Depends upon what minute they're born, and every minute thereafter, what their pulse ox should be. And we can talk a little bit about that. It also depends where you put a SAT probe, right? Whether you should put it on the right upper extremity, because that is, in the newborn, they have this what's called patent ductus arteriosus, where if on the left side of their body, your left upper extremity, you're basically getting mixed venous and arterial blood when you're measuring on the left side until that duct closes. On the right side, that duct being open doesn't matter because it's not mixed on the right side. So if you're going to do a pulse ox, and we'll talk about the numbers, you want it on the right upper extremity, okay? You have to see chest rise. That's your clinical exam to know you're ventilating well. And we'll talk about kind of some of the things that we do to, if you're not ventilating well, you think you've got a good seal, you think you've got bagging well, and you're not seeing the chest rise, what are your possibilities of how to ventilate this baby better? And it's that Mr. SOPA acronym that we'll look at. What are some of your techniques to look at that? Okay, so let's go to the next level. We went from a baby that was, vigorous, put it on mom's chest and fine, to a non-vigorous infant with a heart rate greater than 100. We talked about the first initial steps of sniffing position, suction, blow by. Not improving, we're going to move to room air, positive pressure ventilation with a BVM. Now let's go to that middle category, that if the heart rate is less than 100 beats per minute, what do you do automatically? All right, so that baby needs positive pressure ventilation, right? So if you see obvious secretions and stuff, of course you're going to suction that out and then put a BVM on them. So bag valve mask ventilation with room air at 40 to 60 breaths a minute, perfect, right? You don't even have to hook it up to O2. You just put a BVM on them, start to bag 40 to 60 breaths a minute. And again, you're going to very often see improvement. How do you define improvement in a neonate, right? That, doesn't wake up and respond like our patients we give Narcan to. It's their heart rate, right? So you put their 3-lead ECG on them, you're doing your BVMs, you're giving them, basically you're going to allow them 90 seconds to improve. So over that 90 seconds, you see their heart rate go from 70 up to 90. We're headed in the right direction, and we're going to continue to do just positive pressure ventilation. All right, so really it's listed right here. Primary indicator of effective ventilation is improvement in heart rate, right? That's your key to this whole resuscitation. If your heart rate's getting better, you're doing exactly what you need to do and what the baby needs. And if it's getting worse, you need to up it to the next level of intervention. So heart rate less than 100. So we're going to call it a heart rate of, let's call it a heart rate of 80 is what we're dealing with right now on your monitor. Rates and volumes of ventilation required can be variable. Only use the minimum necessary rate and volume to achieve chest rise and change your heart rate. It goes back to, again, clinical exam, right? How much do you squeeze this bag? You squeeze until you see chest rise. You ensure all the other things that we'll address with Mr. SOPA and reassess, right? You're going to give it 90 seconds. So baby's delivered, non-vigorous, the heart rate's less than 100. You've already done the sniffing position and suction things while they're getting the leads on. And now you provide positive pressure ventilation with room air for 90 seconds. And then we reevaluate where it goes, okay? So if no improvement after 90 seconds, attach the BVM to O2 and you provide 100% oxygen, right? So basically it means that a lot of these babies are going to get better just on room air and some positive pressure. And the ones that are not, now we up the ante to the next level, right? Now we turn up the oxygen, we give them 100% FiO2 and continue with positive pressure ventilation, and we continue to monitor their heart rate, okay? So top category, heart rate greater than 100, heart rate less than 100 but greater than 60. And now we go to the one that probably scares most of us is these babies that are born with a heart rate of 40. So heart rate of 40, heart rate of 50, anything less than 60 in a neonate is not providing adequate cardiac output to perfuse this baby, right? So heart rate less than 60, we're starting CPR right away. How do you do CPR on an infant, right? We used to talk about the encircling thumb technique where you put the baby between your hands and just use your thumbs. We used to talk about putting them on a little board and using 2 fingers. Turns out that the correct way and the most effective way is to do the thumb encircling technique, right? So baby's heart rate is less than 60 beats a minute. Ensure effective ventilation with supplementary oxygen and adequate chest rise, like we've already done, right? So you looked at this baby and you knew and their heart rate was already less than 100 because you could palpate that. You put some positive pressure on them, with their BVM, giving them a little time. Now you've got the monitor on and their heart rate's less than 60. You just turn everything on, right? The O2 goes on, you start doing CPR, and you're going to continue to kind of walk this pathway. So ensure effective ventilation with supplementary oxygen and adequate chest rise. If there's no improvement, this is not in the previous category, we gave you 90 seconds to see improvement, right? So this baby's heart rate is 70, you're bagging them. You maybe even turned on the O2 because you gave them a little more time. You've got 90 seconds to look and see if that baby's improving to decide if you need to kind of increase your intervention. When the baby's heart rate is less than 60, you get a third of that time, right? You've got 30 seconds to see if there's any improvement. So heart rate is less than 60. You're bagging this baby. You've got 30 seconds. So you've got 20 to 30 breaths you're going to give this baby, and you're going to see if that heart rate improves. Okay, so you throw on a BVM, whether it's with O2 or not, right? It really probably doesn't matter quite as much. Ideally, there's probably oxygen hooked up to that. Positive pressure, their heart rate's less than 60. You've got 30 seconds to see if you're going to get improvement by ventilating the baby. If you don't have improvement in 30 seconds, you start CPR. So just because the heart rate is less than 60 is not an immediate reflex that you're going to do CPR. It's a reflex to get ready for it, right? But what you're trying to do is give this baby that little bit of just pressure that it needs, that hopefully the heart rate starts to kick up. And it happens fast, right? You start giving 10 breaths and you see this heart rate go from 40 to 70. You keep doing what you're doing. You don't start CPR, you don't do compressions, you just continue to bag this little infant. But the key is, what I want you to know is your time is significantly decreased when the heart rate is less than 60. Okay, so heart rate less than 60, you have 30 seconds to put a little oxygen and positive pressure into this neonate. And if in 30 seconds there's not an improvement in the heart rate, then you start CPR. Conversely, when your heart rate was above 60 and you're doing positive pressure, you've got 90 seconds to start to see if there's improvement. Okay. So if no improvement after 30 seconds, initiate chest compressions. 2 thumb encircling hands technique is preferred. We talked about coordinate chest compressions with positive pressure ventilation in a 3-to-1 ratio, 90 compressions to 30 breaths. So unlike our big campaign with pediatric and adult resuscitations, where we do asynchronous bagging, we are not doing that in a neonate. Okay, so we are doing the 3 compressions to 1 breath, right? So 1, 2, 3, you stop, you bag, back on the chest. 1, 2, 3, stop, take a breath, right? So you're 3-to-1 with a pause for respiration. Okay, very different than what we've been pushing and touting in all of our other CPR education, because this is not CPR in resuscitation for a pediatric or an adult. This is neonate, which is completely different. Okay, so 90 compressions to 30 breaths if their heart rate's less than 60 and you've already done that 30 seconds of positive pressure. Then you go on to the next level, right? We start talking about blood sugar. We start talking about getting IV access and kind of moving on from there. So the next level down, the EMTI or EMT intermediate, consider establishing an IV or IO access if the heart rate does not improve with BVM. Definitely, right? If you're starting CPR on this baby, we should be starting a line. The best line really in a neonate, I mean, your peripheral line is a challenge. I think it's a challenge for well-trained nurses, and it's certainly going to be a challenge for us in the emergency department and for you guys in the field. So really, the IO is really the way to go. I think it's by far the most effective, most rapid way to obtain IV access is an IO. So make sure you check your kits and you've got the little neonate IOs, and the proximal tibia is still the best one to use. I often will do scalp veins in the ER, but if you're resuscitating a baby, we're not taking time to do scalp veins. We're just going to put an IO in because we're in immediately. Okay, so brush up on, we won't talk about the specifics of that procedure. So if you're unfamiliar with that or you need a refresher, look that up yourself as well on neonate IO insertion. Okay. Establish access if chest compressions are initiated, absolutely. For shock and post-resuscitative care, administer saline at 20 mLs per kilo. So this is going to be a change in the new protocols when we update them. The actual number you want to use is 10 milliliters per kilogram. And this says up to a maximum of a liter, right? That's ridiculous. We're never going to give if you give an infant a liter, right, we've done something very wrong. So the reality is, if we start to get this baby, continually resuscitated and we do some IV fluid, we're going to give 10 milliliters probably of normal saline. It all depends. There's lots of ways to think about this, but probably of normal saline is nothing wrong to do that initially. And it's going to be 10 milliliters per kilogram. So your little 7-pound baby that weighs 3 kilograms, I mean, you're talking 30 ml bolus. And then the way it's going to be written is you'll be able to repeat that as well. So 10 mLs, see where things go, repeat a 10 ml bolus as well. And then it's calling for medical direction after that if you've already done both of those things. Never do a maximum of a liter. We won't even entertain the idea of that much fluid. But just note that will be a change, and certainly start providing that care now, but it'll be in our documentation when we revise these protocols. And then lastly, we've got in chest compressions, your paramedic can start to administer epi. So in ACLS, when we're providing adult resuscitation, obviously a little different, right? Even in that, we talk about really CPR is your best tool to provide in any resuscitation. That's still true in the neonate. It just happens to be more of an airway problem, not a cardiac problem. So when you're given epi to a neonate, again, probably the later stage of what we're thinking about doing, I would focus so much more on the airway and providing good ventilation and good chest rise and good quality thumb encircling CPR over giving epi at any time, right? This is the outcome when you give epi is just not, it's not as beneficial as what we all would think it is, because it's cool to give, to do all this stuff. But epi is not going to be the thing that's going to save this baby's life. It's going to be your good CPR and your good positive pressure ventilation. Okay. We can talk about, going to the next level of, do you check a BGL and do you give D10 and how do you give this? But I think we'll save that for kind of a different kind of discussion. I like to focus on just this NRP, right? Because again, it's all about the airway. Okay. So a couple little tidbits here, and then we'll go over one of the cases. Oh, I wanted to show you, let me stop sharing this screen. And I'll show you Mr. So we'll go over one of the cases we had here this last year and discuss that. But here's the Mr. SOPA acronym, right? So this is really about how do you provide positive pressure ventilation to a neonate and the things to consider. So if you're not getting good chest rise, what do you have to do different? So the first thing is about your seal. So make sure we're in that sniffing position, you've got a good seal, and there's not air leaking every time you bag this baby, okay? So the M obviously is for mask, okay? Second, reposition the airway. That's the sniffing position, right? You got to get the head back and kind of roll off that occiput so that the airway is actually open and not occluded by having their chin down. The big one that I really come back to is going to be secretions, right? So you've got to suction their nose and their mouth, and if you see a meconium or snot or whatever that's coming out of this baby's airway, you've got to get it out of the way in order to provide, good positive pressure ventilation. And this is a huge one. So very often we find it's just secretions that are occluded in the airway or stuck in the airway that you get out. Now the baby breathes fine. We do not do this whole, intubation for meconium suctioning thing anymore. That's really been 20 years ago, 15 years ago. That's gone by the wayside. So if you think about that or hear about that, that's just kind of the old way of thinking. But there is no occasion to intubate just because of meconium in the airway. The O in Mr. SOPA is open the mouth. So if you're not getting, you've got a good seal, you've repositioned the airway, you've suctioned out. Your next thing is just, like an adult, if you're not bagging well, you provide a little jaw thrust. Neonate, it's like fingers behind their little condyles and just a little lift there as well. Take a little bit of pressure off their airway. And then, the pressure, you can increase pressure. So if we have these blow-off valves on the BVMs, you can titrate that up. You go from 20/5 and increase by 2 and titrate it up to 22/5 or 22/7 and kind of move up slowly. Increasing the pressure is the other way. That's probably moving down the line. You're hopefully at the hospital by the time we get to that, part. And then lastly, for the A and Mr. SOPA is it just time to intubate the baby? So let's look at a case that we had here. Drag this down just a little. So this is a case we had here. There's only 2 vital signs listed. So my only critique of this chart when we talk about it is just that there's not a lot of documentation with vital signs. That's because you're busy, right? You don't have time to stop and document all this, and I get it. And it's nice to have, and it's nice to see the progression and provide the education of where this baby started and ended and how it got there. But you provided really good care for this baby, and that's probably what matters more than anything. But the only 2 vital signs in there, we'll talk about it, upon 1623 is the arrival time. And they show up in the baby. CPR is actually in progress and the baby's heart rate is 58. Right? So here's your story. You're dispatched emergency traffic for a home birth with complications. There's a newborn that was pulseless and apneic with CPR in progress. So just thinking about this, right? So you're in that bottom pathway when we talk about the non-vigorous infant, right? We're not at the top, the middle, but we're at a heart rate less than 60, CPR in progress, and you're hoping somebody's providing positive pressure ventilation if this was a provider there or midwife or something like that. So here's the story. Upon arrival, found the father of the baby at the front of the house, stating the baby and mom were in the back room. Midwife was performing CPR on the baby while the mother was lying in bed, still delivering the placenta. Midwife stated that the baby was delivered about 40 minutes prior to EMS arrival with no complications. On arrival, the baby was pulseless and apneic with the cord still attached to the placenta. The placenta was not delivered before our arrival. Midwife states that the mother of the baby had no high risk factors for delivery complications, which they never do, right? The ones that have a problem are never the ones that you anticipate having a problem. The mother did have prenatal care with routine checkups, and the mother denied any drug or alcohol use. Right. So sometimes, again, that's another factor. You start throwing in drug or alcohol abuse, and is this a baby who's in, alcohol withdrawal or opiate withdrawal or opiate, respiratory depression? Different kind of factor. Treatment's not going to change acutely for this, but more things to talk about. So baby was pulseless and apneic, skin is pale but warm on arrival. CPR suction with bulb suction. Each suction produced dark, thick substance thought to be meconium. Absolutely, right? This is what's in this baby's airway. You've got to get out. And they did that while doing CPR and noticed this. So this is perfect. Attach the pediatric defib pads, an OPA. Now, this is questionable, right? Do you put an OPA in that little tiny one? Plus or minus, right? You're probably not harming, as long as it's not too big of a one. There's no harm in doing that, but often just putting them in that sniffing position is what really opens their airway. BVM with high flow 2, midwife clamped and cut the cord and gave advance notice to LAMC that the pediatric CPR was in progress. I'm not trying to critique anybody's, stuff here, but a cord that's still attached after 40 minutes, I honestly don't know the long-term complications, or could that lead to, the distress in this baby. But we should be, if you notice this cord is still attached, that should be one of the first things that we take care of. Clamp it, in 2 spots and cut in the middle and get mom unattached from this baby, so this baby can start to close the ducts and things that need to happen when they take their first breath. Then patient was transported, emergency traffic to LAMC with CPR and BVM with high flow suction, gave radio report, and there's mixed stories. So this was a really good case, right? So basically, this crew showed up, there's CPR in progress on a neonate. They took over, put the BVM on, started positive pressure, continued CPR, loaded up and rolled to the hospital. By the time they got here, heart rate's in the 140s, almost 150s. We had great advance notice. We had the neonatologist in the ER by the time you guys got here. We don't talk about IV access, and maybe there was IV access obtained or an IO. Would an IO change anything in this? Again, probably not, right? This is all about airway. So providing positive pressure, thank you, positive pressure ventilation is what's going to change this outcome. And that's what these guys did. So you guys did a wonderful job. There's not a lot of detail, because you were busy. So I think you did a great job. The end result was this baby did really well. Spent some time in the NICU, and I saw a picture of the baby, I don't know, last week sitting in a car seat or something. I mean, this baby's fine. Long term, what's the outcome? You really don't know for a couple of years of if there was anoxic brain injury or what the long-term sequelae will be from that. But on our end, from an EMS standpoint, you guys did a fantastic job, provided rapid care, rapid transport, and CPR with positive pressure. So I think everything was done really well. Let me just see if there's anything else I want to tell you. I think that's probably good enough. What's our time? 36 minutes? That's plenty of time to have that discussion. So thanks for paying attention and listening. I always appreciate you guys taking the time to do this. And I know you have lots of training to do and things to read over. So I always appreciate you taking the time to listen to what I have to say. And again, if you have questions, come by and talk to me, talk to your medics, send questions to Captain Pacheco, whatever's easiest for you, that we're happy to provide some more education. And I think that's it. So again, thank you so much. And we'll talk to you next time.